In this lesson, we are going to be talking about the thoracic spine. This discussion will involve both the thoracic vertebrae as well as the ribs. Let's get started by talking about rib terminology. On COMLEX and in-class exams, test writers love to go after this concept because there are so many different ways that we can describe, classify, and identify ribs. During this discussion, I will keep this image that you see on the side of the slide for your reference. Our discussion should begin by talking about true versus false versus floating ribs. True ribs are ribs that have direct attachments to the sternum. So as you see in this image, ribs 1 through 7 are true ribs because they have cartilages that extend from the ribs and connect those ribs directly to the sternum. False ribs are ribs that indirectly attach to the sternum. As you can see in this image, this includes ribs 8, 9, and 10. Ribs 8, 9, and 10 have cartilage, but that cartilage actually connects to the cartilage that comes off of rib 7, which then carries indirectly to the sternum. So yes, technically ribs 8 through 10 do attach to the sternum, but that attachment is indirectly made through the cartilage that comes off of rib 7. Therefore, ribs 8, 9, and 10 are referred to as false ribs. Finally, we have floating ribs. These are ribs that do not attach to the sternum at all. And although it's difficult to see in this image, and I'm going to change the image in just a second, this represents ribs 11 and 12. Now let's get a new image and color code this for your studying pleasure. You can see that true ribs are ribs 1 through 7. They are shown in red. They have direct attachments to the sternum from their own cartilage. False ribs, shown in green, are ribs 8 through 10. These ribs do have cartilage, but this cartilage actually attaches to the cartilage from rib 7, and indirectly, these ribs are attached to the sternum. Lastly, we have our floating ribs. This is represented in blue. These are ribs that have no attachment to the sternum at all, and that's ribs 11 and 12. The clinical significance of true, false, and floating ribs is shown on this slide. For both true ribs and false ribs, as you descend inferiorly, so going from rib 1 to down to 2, down to 3, etc., as you go down, you increase the length of the rib and the curvature of the rib. For floating ribs, there are small costal cartilages that terminate in the lateral abdominal wall. So although the cartilage doesn't attach to the sternum because it's a floating rib and there are no attachments directly to the sternum, you should know that there is small costal cartilage that terminates in the abdominal wall. Now, true, false, and floating ribs are not the only rib terminology that you need to know. You also should be comfortable with the distinction between typical ribs and atypical ribs. Typical ribs have a predictable head, neck, and body that's the same regardless of which rib number you're talking about. Typical ribs have two facets. One articulates with the same numbered vertebrae, and the other facet articulates with the above numbered vertebrae. Typical ribs also have a curved shaft with a neurovascular groove. And recall from anatomy that neurovascular groove carries not only vasculature, but also nerves. Now, the atypical ribs don't have these predictable features. We'll talk about which ribs are typical versus atypical, but let's go through the atypical ribs one at a time just so you can get an idea about what makes these atypical ribs so different. Rib number 1 only has one facet, and it also has 2 grooves for the subclavian vessels. Rib number 2 has a rough or roughened area where the serratus anterior muscle attaches. Rib number 10 only has one facet. Ribs 11 and 12 not only have no neck, but also, just like rib 10 and rib 1, only have one facet. So how do you remember which ribs are typical and which ribs are atypical? The easiest way to do this is to just know that atypical ribs are any rib that has the number 1 or 2 in the rib number. So let's look at this. This would be ribs 1, 2, 10, 11, and 12, because all of those ribs have either a 1 or a 2 in their number. If you memorize this, it'll be easy to remember the typical ribs, because typical ribs are just all the others. All right, so just note the atypical ribs with the 1-2 rule, and then by the process of elimination, you'll know that the typical ribs is pretty much everything else. Now let's switch gears and talk about rib motions. When physicians describe the various motions that ribs perform during the breathing cycle, they can be said to be pump handle, bucket handle, or caliper motion. Ribs 1 through 5 are pump handle ribs. This means that in the breathing cycle, the anterior posterior diameter, or AP diameter, increases with inhalation. For your convenience, I will put pictures of the tools or the items from which these names are derived so you can see what the motion actually looks like. So the reason that ribs 1 through 5 are referred to as having a pump handle motion is because the AP diameter moves exactly like the handle of a pump. Ribs 5 through 10 are known as bucket handle ribs. Bucket handle is what you would expect when the transverse diameter increases with inhalation. So this happens out laterally. The transverse diameter is moving, and that's what the handle of a cleaning bucket would do if you swung it over the side of the bucket. Now note, ribs 1 through 5 are pump, but 5 through 10 are bucket. And depending on the source that you use, rib 5 can be pump or rib 5 can be bucket. So I'm just pointing that out because there is a bit of overlap in the types of rib motion at rib 5. Lastly, caliper motion. Caliper motion is ribs 11 and 12, and it's said to have a, quote, down and out motion during inhalation. Now that you understand the rib motions, let's talk about the highest yield part of today's video, of this thoracic video, which is rib dysfunctions. Rib dysfunctions can either be inhalation dysfunctions or exhalation dysfunctions. Now remember, we name dysfunctions or somatic dysfunctions, which these are both somatic dysfunctions, but generally speaking, we name dysfunctions for their ease, for the direction that a segment, a group, a structure prefers. So an inhalation dysfunction, the rib is stuck up. When you breathe in, when you inhale, your ribs go up. So if you have an inhalation dysfunction, the dysfunctional rib is stuck up. That is to say, the rib prefers to move up into its ease, and it does not want to move down into its bind. Now let's look at the opposite of that, an exhalation dysfunction. When you breathe out, the ribs go down. So in an exhalation dysfunction, the rib is stuck down. The rib prefers to move down into its ease, but it does not want to move up into its bind. Now, one very important thing, an incredibly high yield fact to know for COMLEX, in-class exams, practicals, you name it, is to know about the key rib in an inhalation dysfunction and the key rib in an exhalation dysfunction. Generally speaking, the key rib is the rib that you have to treat first in an inhalation or an exhalation dysfunction to free up the other ribs that are also dysfunctional. In an inhalation dysfunction, the key rib is the bottommost rib. In an exhalation dysfunction, the key rib is the topmost rib. Now let's spend just another minute here because this is a very, very high yield concept. In an inhalation dysfunction, the ribs are stuck up. So these dysfunctions encompass groups of ribs. So let's do an example. Pretend that ribs 2, 3, and 4 are inhalation dysfunctional ribs. This means that this group of ribs collectively is stuck up. The key rib is the bottommost rib in the dysfunctional group. So in this case, the key rib is rib 4. The reason that the key rib is always the bottommost rib in an inhalation dysfunction is because if these ribs are stuck up, in order to get them back down, you have to first address key rib number 4. Because think about it. key rib number 4 is blocking ribs 2 and 3 from being able to move back down because all 3 are stuck up. And if you want to move them down one at a time, you have to treat the bottommost key rib first, because if you tried to treat rib 2, it wouldn't be able to go anywhere because the rib 3 is in its way. If you tried to treat rib 3 first, it wouldn't be able to go anywhere because rib 4 is also stuck up and blocking rib 3. Therefore, I'm going to repeat myself because it's incredibly important you understand this. You treat the key rib first, and in any inhalation dysfunction, the key rib is the bottommost rib. Let's look at an exhalation dysfunction. In an exhalation dysfunction, the ribs are stuck down. So pretend that ribs 2, 3, and 4 had an exhalation dysfunction and all 3 of those ribs were stuck down. You have to treat the key rib first. And in an exhalation dysfunction, the key rib is the topmost rib. Think about it. If 2, 3, and 4 are stuck down and you want to get them back up, if you started by treating rib 4, it wouldn't be able to go back up because 3 is also stuck down and therefore it's blocking rib 4. If you tried to treat rib 3 first, it wouldn't be able to go back up because rib 2 is also stuck down and therefore rib 2 is blocking rib 3. So it should make sense that in an exhalation dysfunction, the topmost rib is the key rib. And again, we always address and treat the key rib first. So incredibly important to understand the key rib, treating it first, and then knowing whether it's bottommost or topmost, depending on inhalation versus exhalation dysfunction. Now, if you're comfortable with that idea, we need to talk about how we treat exhalation dysfunctions. In exhalation dysfunctions, we use a subtype of muscle energy to pull the ribs back up because, again, in an exhalation dysfunction, the rib is stuck down. It prefers to go down. And therefore, the goal is to pull that rib back up using what's known as muscle moves the bone technique. Now, technically, muscle moves the bone is a subtype of muscle energy, and the principles are pretty much the same. But the goal is to get the muscle, which is attached to the rib, to contract. And when that muscle contracts and you hold that contraction in a muscle energy like subtype technique, you pull that rib that's stuck down back up. Therefore, depending on which rib is stuck down, there's different muscles that we would target to use this technique because, of course, there are different muscles that attach to different ribs. So the tough part for COMLEX and whatever exam you're taking is to memorize which muscles you target depending on which ribs are dysfunctional. And that's what we're going to talk about right now. So rib number 1 has attachments to both the anterior and middle scalene. Recall from a previous lesson, I told you that it would be very, very high yield to know where the scalenes are attaching, and this is the reason why. The anterior and middle scalene both attach to rib 1, which means if we use this subtype of muscle energy, again referred to as muscle moves the bone, if we contract the anterior and middle scalene, we can pull that rib back up. So if rib number 1 is in an exhalation dysfunction and you use this technique, you'll pull it back up. Rib number 2 has attachments to the posterior scalene, here shown in green. So if we have rib number 2 stuck down in an exhalation dysfunction and our goal is to get it back up, we would use this technique and contract the posterior scalene to pull that rib number 2 back up. So here's a chart, and we should probably fill this in because this is very, very high yield to know for COMLEX as well as in-class exams, what muscles you're going to target and use depending on which ribs are in an exhalation dysfunction. So we just said that for ribs 1, you use anterior and middle scalene. For rib 2, you use posterior scalene. For ribs 3 through 5, you're going to use the pectoralis minor, which my mnemonic to remember this is that pec has 3 letters. So you start at rib 3 and you go for 3 ribs. So starting at 3, because pec has 3 letters, and then going for 3 ribs, ribs 3, 4, and 5, you use pec minor. Ribs 6 through 9, you're going to use the serratus anterior, which again, my mnemonic is look at the S in serratus, and 6 starts with S, so that's pretty easy to remember. And lastly, ribs 10 through 12, you'll use the latissimus dorsi. So know these ribs, know the muscles that attach to them, and therefore the muscles that you'll use in this subtype of muscle energy to pull those ribs back up. Let's talk about some thoracic anatomy that you need to know. First, landmarks. Knowing your landmarks is important, not just for COMLEX, because yes, it gets tested, but also in your in-class practicals when you're actually palpating somebody's thoracic spine and you're trying to figure out what level you're at. So T3 is where you would expect to see the spine of the scapula. And I'm going to mark these for you in the image. So the top red line is the level of T3. T7 is where you'd expect to find the inferior angle of the scapula. So you can see them both in this image, the spine and the inferior angle. There's really only one major muscle that you need to know in the thoracic region, and that's your diaphragm. The diaphragm is the major muscle involved in breathing. So you need to know its attachments and its innervation. The diaphragm attaches from L1 to L3 and ribs 6 through 12. Perhaps the highest yield fact here is its innervation. The diaphragm is innervated by the phrenic nerve, and please don't forget the mnemonic C3, 4, and 5 keeps the diaphragm alive. Let's conclude this video by talking about the rule of threes. The rule of threes is a rule that describes the anatomical and spatial relationship between the spinous and transverse processes in the thoracic spine. So if I zoom in on an image of the thoracic spine, what you'll note here is that as we descend inferiorly, the line between the transverse and spinous process changes over time. So let's look at the first vertebrae in this image. You'll note that the transverse processes, which have the two laterally pointing black arrows, and the spinous process, which has that downward small arrow, they're in the same horizontal plane. But if we jump down to a later vertebrae, you will notice that where those blue arrows are, I'm pointing to the two transverse processes, which of course are in the same line because they're both transverse. But then look at that vertebrae's spinous process. It is well below the line of its transverse processes. And because that relationship changes depending on which thoracic vertebrae you're looking at, this becomes quite high yield for COMLEX, and test writers will love to see if you understand the relationship spatially between the spinous and transverse process. Now, because of that, you need to memorize and take away from this lecture the chart you see on this slide. And we call this the rule of threes because we group the thoracic vertebrae into groups of three. So let's separate them now. We'll have T1 to T3, T4 to T6, T7 to T9, and then T10, 11, and 12, each as their own special rule. So let's fill in the first three rules of the rule of threes. From T1 to T3, the spinous process and the transverse process are in the same horizontal plane. So same line, nothing to know. As you go down to the next rule of three, which is T4 to T6, so the next grouping of the next three thoracic vertebrae, the transverse process is 1/2 segment above its corresponding spinous process. Going to the next rule of three, from T7 to T9, the transverse process is 1 full segment above its corresponding spinous process. So I know that this may seem vague and abstract at first glance, so let's just do an example. If I gave you T8 and I said, where is the transverse process of T8 in line with? Since the transverse process of T8 is 1 full segment above its corresponding spinous process, what that means is that the transverse process of T8 is actually in line with the spinous process of T7 because it's 1 full segment above. Now from T10, T11, and T12, we fill in those three rules using the three rules that we already filled in, but now we just go backwards in reverse order. So T10 will follow the same rule as T7 to T9 because we're just going backwards in reverse order. T11 will follow the same rule as T4 to T6. Again, we're going backwards in reverse order. And lastly, T12 will follow the same rule as T1 to T3, again, because we go backwards in reverse order. So how is the best, what's the best way to memorize this? if you know the rules from T1 to T3, T4 to T6, and T7 to T9, grouping them by threes, you then just go backwards for the next 3 vertebrae. So the rule of threes is very, very high yield. I know it's a burden to memorize, but the fact that it's a burden is what makes it high yield. Test writers know that med students don't want to memorize this, so expect a question on this topic.